Hi folks, I'm going to talk today about chapter 22 out of your textbook. This covers the respiratory system. I hope that you have, I know that you have had access to the list that I sent you for all of the figures and tables that I'd like you to get printed, as well as the study guide that's at the end of the chapter. It's also good to copy that and use it for your study and your preparation for the examination. Now, I want to remind you again that this lecture of sorts cannot take the place of reading very closely, very carefully your textbook. What I want to do, what I intend to do by going through this is just to highlight the points and the facts that I'd like you to spend most of your study time looking at. We'll start with section 22.1, the anatomy of the respiratory system. First, a couple of definitions. Ventilation. The word ventilation means moving air in and out of the lungs. Respiration it refers to cellular respiration, and that is the gas exchange of oxygen and carbon dioxide that takes place at each and every cell in the body. Now, the respiratory system is an organ system. Your author says that rhythmically takes in air and expels it, thereby supplying the body with oxygen and expelling carbon dioxide. Now, he or she or they list 8 different functions, and this is on page 849, and I'd like you to highlight those and go through them so that you could pick most of those off a multiple choice question. The conductive system, or the conductive division, anatomically speaking, of the respiratory system consists of the pharynx, the trachea, and many of the bronchi, down through the major bronchioles. The respiratory system actually consists of the smaller respiratory tubes, respiratory tracts, and the alveoli. Please look at and study figure 22.1 on page 850. Your author then goes on to describe and detail all of the different anatomical regions of the respiratory system. Starts out with the nose or the nares, the pharynx, the larynx, which is another name for the trachea. The larynx is the voice box, rather. These are covered in figures 22.3 and 22.4 on pages 852 and 53. The trachea, or the windpipe, is a very rigid tube that's supported by C-rings of cartilage. This is shown in detail in figure 22.7, page 855. The trachea comes down to behind the sternum and then splits into the right and the left main stem bronchi. If you look closely at that picture, you will see that the right main stem bronchus goes down straighter, and the left main stem bronchus bends a little more to the left, and that is because that the heart is located right there, very near the main bronchi. Okay, skipping ahead, my pages are slick here, I'm sorry. I want you to look at page 856, figure 22.8. This is an amazing, beautiful little photomicrograph showing the epithelium of the trachea, showing the ciliated cells and the non-ciliated goblet cells. I want you to realize that each and every part of the respiratory system, and we will see later also in the gastrointestinal system, is lined with an epithelium that can secrete mucus. It is essential that the inside of these two systems be kept moist. The ciliate or the mucus actually will trap particles that we don't want being sent all the way down to the alveoli. And then these cilia actually will move this mucus upward and allow us to clear it out of the respiratory tract. Look please at figure 22.9 on page 857. Two things to see there. One are the different divisions of the trachea and then the bronchi. I showed you before, I mentioned the right and left main stem bronchi, and then these split into lobar bronchi, 3 in the right lung because there are 3 lobes, and 2 in the left lung because there are only 2 lobes. And then these lobar bronchi split again and again and again like an upside down tree until we get to very, very tiny terminal bronchioles that are indeed microscopic. If you look at the mediastinal surface of the right lung, you can see the pulmonary arteries that are shown in blue here because they have deoxygenated blood coming from the right ventricle. The pulmonary veins have red blood that is oxygenated, and they are going to return this oxygenated blood back to the left atrium, left side of the heart. The respiratory bronchioles all end in what are called alveoli, alveolar sacs, and then alveoli. If you look at the figure 2211 and 2212, pages 858, 859, you will see actual stained photographs and then unstained photographs, a scanning electron micrograph showing alveoli, and then artist pictures of the alveolar sacs, each containing numerous individual alveoli like a bunch of grapes. The alveolus is where gas transport takes place, and you will see in part C, or little diagram C of figure 22.12, how the alveolus on the left-hand side comes in very, very close contact with a small capillary, and they are only separated by an extremely thin three-layered respiratory membrane. This allows carbon dioxide and oxygen to diffuse across from one side to the other very, very easily. You might also be interested in knowing that in the alveolus there are also macrophages that can destroy any foreign substances that might make their way all the way down into the alveoli. Okay, section 22.2. Well, let me just mention, before we get to that, on the left-hand side of page 860, I want you to know the two layers of the pleura. The visceral pleura actually is firmly attached to the surface of the lung and extends into the fissures between the lobes of the lung. The parietal pleura lines the inside of the thoracic cavity, and this is a closed space. It will expand and contract in order to draw air into the lungs and to expel the air back out of the lungs. That is what we will describe in section 22.2, pulmonary ventilation. Inspiration, or also called inhalation, is the movement of air into the lungs. Expiration, or exhalation, is the movement out of the lungs. One complete breath in and out is referred to as the respiratory cycle. I do also want you to know the difference between quiet, relaxed respiration and forced respiration. Look please at figure 22.13, and here you will see the listing of the respiratory muscles. On the left-hand side shows the muscles that are very important in inspiration, to taking air into the lungs. Expiration, quiet expiration, actually does not require any muscles because it is a passive movement, just the chest wall going back to its original shape and pushing air out of the lungs. Forced expiration, however, requires the use of other muscles that you will see on the right-hand side of figure 22.13. Just like the heart rate and rhythm, our breathing rate is controlled in the brainstem also. There is the brainstem respiratory center, which is located, as you can see, in the pons and medulla oblongata of the brainstem. This is a very, very complex system that I don't expect that you will memorize at this point. You will learn it better when you go to medical school. Now, what gives input into these respiratory centers? You can see in figure 22.15 that there are some peripheral chemoreceptors of respiration. These are aortic bodies, the carotid body. These can sense how much oxygen and carbon dioxide are present in the air, and can then give nerve impulses to the respiratory center in the brainstem to breathe faster and or deeper. There are also peripheral chemoreceptors, stretch receptors, and what your author calls irritant receptors. I don't expect you to memorize the physics of this airflow, but it is a good idea if you learn the terms of atmospheric pressure, that is the pressure outside of the lungs, and the intrapulmonary pressure, and that is the pressure in the pulmonary or in the cavity between the pleura. In order for us to breathe in or out, there must be a difference in pressures between these two areas. And it might surprise you just a little bit, but it is only a very little bit of pressure that can allow air to move into and then back out of the lungs. Okay, now there are various things that give resistance to airflow. It is not as simple as it might seem. The bronchi actually are surrounded by smooth muscle, and these, when this muscle contracts or dilates, we can have bronchoconstriction or bronchodilation, and this will allow the air to move more difficult or easier in and out. One of the problems in a person with asthma is that these bronchi tend to constrict, making it more difficult to breathe. A person with extra mucus also has smaller airways, and this is the primary cause of problem in someone who has a disease called chronic bronchitis due to cigarette smoking or long-term exposure to very dirty air. If there is extra mucus and extra inflammation, then this also causes more resistance to airflow. Figure 22.16, though it's out of place with your reading, shows the respiratory cycle. And it is good if you go through the steps 1, 2, 3, and 4. And you will see that the pressure differences between the intrapleural space, the intrapulmonary space, and the atmosphere, the difference is only a very, very slight amount. Here, your author is using centimeters of water pressure instead of millimeters of mercury, which is a more common term used for atmospheric pressure. Another term I want you to know is pulmonary compliance. And that term refers to the ease or difficulty with which the lungs are able to expand and then contract. Degenerative lung diseases, such as tuberculosis, emphysema, or chronic bronchitis, decrease this compliance and again make it extremely difficult in order to breathe. The term alveolar ventilation is defined as the amount of air that moves in and out of the lungs during 1 minute. And your author shows some examples there of between 4,000 and 5,000 milliliters of air per minute. This is alveolar ventilation. Skip now over to page 870 and look at both figures 22.17 and table 22.2. 22.17 shows a tracing that comes from a machine that you see this young fellow using in photograph A. He is doing what is called a pulmonary function test. Let me just talk through that. As the paper is moving, he is just taking resting breaths in and out, and then he breathes in where the curve goes down, and then back up again, and then he blows out as much as he can, and the curve goes all the way up. Then it comes back down, resting, and then back up and back down. That is when he is blowing out absolutely as much air as he possibly can. And then he goes back to resting breathing. These are various capacities and volumes that have been defined for children, adult females, adult males, and you will see some of these typical values in table 22.2. Any person who is specializing in caring for people with lung problems does many of these respiratory or the spirometry tests to see how well a person is breathing, and then often we'll try it again after some kind of medication is used to see if there is improvement. We now have moved air into the lungs. Now let's talk about section 22.3, starting page 871. How is gas exchanged and then transported through the rest of the body? There is a small discussion there about the composition of air. The air that we breathe is only about 21% oxygen. That is all that we need. It is about 79% nitrogen and just a very small amount of carbon dioxide. All of these gases give what's called, each of them individually gives a partial pressure. And then if you add those pressures together, you will see in the equation there on page 871, this total of 760 millimeters of mercury. And again, that's back to what I described, a different set of numbers for measuring air pressure. Okay. If you look at figure 22.4, you will see the composition of both inspired and alveolar air for nitrogen, oxygen, and carbon dioxide. You don't have to memorize these, but it is a good idea to at least have a general idea of what normal numbers should be. As I mentioned, the gases exchange by simple diffusion in the alveoli. There are various variables that determine how fast or how much gas is exchanged. And I want you to at least understand the author mentions 5 different variables. The difference between the partial pressures of the oxygen or the carbon dioxide on each side of that respiratory membrane. Number 2 is the solubility of the gases in water. Number 3, the membrane thickness. The thicker the membrane, the more difficult or the slower that gas exchange will take place. Membrane area seems quite easy. The more area there is, the better that the air can move across. And then a concept called ventilation perfusion coupling. And this is a difficult to understand concept. The body has a physiologic response that is involuntary that matches the airflow to blood flow. A look again at figure 22.19, and you will see some typical numbers there of the changes in the partial pressures of oxygen. That's what PO2 means, partial pressure. P sub O2, P sub CO2 along the circulatory routes. It shows oxygenated and deoxygenated blood in the tissue, in alveolar air, air in the atmosphere, etc. If you are doing, if you're going to medical school, or if you are studying to be a pulmonologist, you will have these memorized. But I don't expect that you know these numbers now. If you take a quick look at figure 22.21 on page 875, you will see some pulmonary alveoli. At the top, figure A shows a normal cross-section of a alveolar group of alveoli in the lungs. Picture B shows pneumonia. Pneumonia means that there is extra fluid and infection actually inside of the alveoli. That causes great difficulty breathing. And then finally, you can see the destruction that is done to a lung due to emphysema. And this is due pure and simple to smoking cigarettes, cigars, pipe, anything that destroys the alveoli in the lungs. Okay, the next few pages are extremely complex, and I want you to at least have skimmed through them. You will notice that there are many, many variables that take place between across the respiratory membrane into the alveoli, and then between the capillary and tissue that the capillary supplies with gases. This is very complex. And once again, I don't expect you to have memorized all of this at this point. I do want you to know that about over 90% of the oxygen that is carried in our bloodstream is attached in the red blood cells to hemoglobin. Just a very small amount is dissolved in the liquid of the blood. Carbon dioxide is also both combined with cells in the blood as well as dissolved. You might want to go back through that and see those percentages. I'm not going to talk about all of the different diseases of the lungs. You might get one question on that on your test. You can see table 22.5 lists some disorders of the respiratory system, including acute rhinitis. Sounds terrible, doesn't it? It's a fancy name for the common cold. There's ARDS, adult respiratory distress syndrome. This is a grave problem that can end up causing death. Pneumonia, we showed, that is an infection deep inside the lungs, as opposed to bronchitis that is just an infection in the bronchi. Tuberculosis is likewise very deadly, especially overseas it is one of the more common causes of death in people that are HIV positive and have AIDS. The tuberculosis infection is both inside the alveoli as well as in the pleural space, making it impossible to breathe. Next time you decide to light up a cigarette, you might want to copy picture 22.27 and carry that around with you, stuck in between the pack of cigarettes and the plastic on the outside. Think, that's what my lungs look like. And deep inside of there, oh, okay, it says smoker's lung with carcinoma. Do you know what carcinoma is? That is another term for a malignant tumor. And you can see two of them pointed out. Most common cause of cancer in the lungs is squamous cell cancer, and that is also due to smoking. With that, I will quit. Hopefully you've given up smoking by now. And I'll see you again, talk to you again when we talk about chapter 23. Thanks.